All right, welcome everyone to part one of our comprehensive 20-part dental coding masterclass series. Look, if you're a medical coder, a dental biller, a CPC or CDT aspirant, or really anyone in the revenue cycle space, you are in exactly the right place. Over the course of this series, we're going to transform you into absolute experts in navigating current dental terminology, or CDT. But, before we dive into the really complex world of numbering systems and modifiers, we have to start at the absolute foundation. Why? Because mastering tooth anatomy is the mandatory, completely non-negotiable first step for accurate CDT and ICD-10-CM code selection. Literally, if you don't know the precise anatomical layer a dentist is working on, you simply can't code the procedure accurately. So get comfortable, take some notes, and let's start building that foundation today.
Okay, let's quickly lay out today's roadmap. We're going to start by defining dentistry. Then we'll map out core tooth anatomy, look at the actual coding and clinical relevance of those structures, and then wrap things up with a summary and next steps.
First up, Section 1, Defining Dentistry.
Now, we really need to expand our traditional view here. Dentistry isn't just about teeth, right? It's comprehensive oral medicine. It's an entire specialized branch of medicine totally focused on the health of the teeth, the gums, and the whole oral cavity. As coders, we're documenting the evaluation, the diagnosis, the prevention, and the treatment of diseases and conditions affecting the mouth. But here is the absolute critical takeaway for your medical records. Dentists play a huge role in maintaining overall health. They routinely identify systemic conditions, larger whole-body issues that just happen to physically manifest in the mouth. So when we're coding for oral evaluations, we are very often coding for the frontline detection of these much broader medical conditions.
Moving right along to Section 2. Core tooth anatomy. We're going to take a physical journey starting from the visible surface of the tooth straight down deep into the jawbone.
So our anatomical journey starts right at the top with the crown. The crown is simply the visible part of the tooth that sits above the gum line. When a dentist is doing a standard visual exam of a patient's mouth, or honestly, just when you smile in the mirror, the crown is the anatomical structure you're looking at. From a billing perspective, a vast majority of your surface-level restorative work is going to be mapped directly to this visible area.
And acting as the ultimate outer shield of that crown, we have the enamel. This is the incredibly hard layer that protects the tooth from damage and decay. Fun fact, it's actually the single hardest substance in the entire human body. No joke. As a dental coder, you are frequently going to see procedures aimed at protecting this specific layer, things like the application of fluoride or sealants, which are entirely designed to reinforce this protective shield.
Okay, moving a little deeper into the tooth, we hit the dentin. Located right underneath the enamel, dentin makes up the vast majority, the real bulk of the tooth structure. Now, unlike that rigid enamel, dentin is much softer. And crucially, it carries tiny nerve signals through these microscopic tubules. When a patient comes in complaining of a sensitive tooth, it's very often because that protective enamel has worn away, exposing this highly sensitive dentin layer underneath.
Journeying even deeper, we finally arrive at the core, the pulp cavity. This is the innermost part of the tooth. Think of it as the vital vascular and nerve center, just completely packed with nerves and blood vessels. Its main job is to nourish the tooth and provide sensory function. When decay breaches the enamel, eats completely through the dentin, and reaches this pulp cavity, well, we're no longer dealing with a simple filling. We are now in the territory of severe pain and much more complex, deeper interventions.
Dropping below the gum line now, we find the root. The root is the part of the tooth that's physically embedded in the jawbone. Its fundamental role is basically to act as an anchor, holding the tooth securely in place within the alveolar bone. And procedures involving the root are fundamentally different from those involving just the crown, both on the clinical side and, of course, in your coding manuals.
Covering that root is the cementum. This is a highly specialized, super thin layer that protects the outside of the root. But it doesn't just protect it, it actually serves a vital mechanical purpose by helping to firmly attach the root to the jawbone itself.
And we conclude our anatomical breakdown with the periodontal ligament, or the PDL. Basically, think of this tissue as the tooth's built-in suspension system. It acts like a crucial shock absorber whenever you chew, enduring all that mechanical stress and keeping the tooth remarkably stable within its socket. When we get into periodontics, which is the treatment of the gums and supporting structures, this ligament becomes a major player.
All right, Section 3, Coding and Clinical Relevance. Let's see this anatomy in action.
So, why does all this matter? Well, this is where the magic happens for us as coders, because anatomical depth literally dictates your coding decisions. Think about it. Let's compare two scenarios. If a dentist is doing preventative surface treatments, say applying sealants or fluoride to that hard outer enamel, you're going to be looking in the D1000 to D1999 series of your CDT manual. But if they have to repair a tooth damaged by decay in the dentin and enamel, boom, you're in the D2000 series for restorations. However, if that decay goes all the way down into the innermost vascular core, the pulp, the dentist has to perform endodontic treatment, like a root canal. And for treatments of the dental pulp, your codes completely shift over to the D3000 to D3999 series. If you don't know the difference between the enamel and the pulp, there's no way you'll know the difference between a D1000 preventative cleaning and a D3000 endodontic surgery. For us, anatomy is everything.
Which brings us to Section 4, Summary and Next Steps.
To really cement this terminology in your memory for your certification exams and your daily revenue cycle workflow, let's rapidly recap the 7 core layers we just conquered. We have the visible crown, shielded by the ultra-hard enamel. Beneath that is the softer dentin, which surrounds the vital, nerve-filled pulp. Then, dropping below the gums, we have the root, anchoring into the jaw, covered by the attaching cementum, and finally stabilized by the shock-absorbing periodontal ligament. Memorize these 7, and you are well on your way.
So we've got the vertical layers of a single tooth down, right? But what happens when we zoom out to the entire mouth? If a dentist operates on a mesial surface of an interior tooth, would you know exactly how to code it? Well, that's our Part 2 preview. Make sure you like this explainer, subscribe to the channel, and check out the playlist for Part 2 so you don't miss a thing.
Decode Healthcare with Harshal.